Good evening, everybody, and thank you for giving me this opportunity to talk about cardiac PET imaging. I'm going to talk on cardiac metabolism PET and a little bit about the intricacies of the complexities involved in doing these studies. Financial disclosures, I have none. We'll review the appropriate indications for PET and talk a little bit about the various patterns you see in various indications for this. So as we all know, cardiac PET can be done for myocardial perfusion imaging as well as cardiac metabolism imaging. The indications for that are basically evaluation of myocardial viability, scar prior to EP procedures, and for cardiac inflammatory and infectious disorders like cardiac sarcoidosis. Metabolism of the heart has very complex underlying conditions as regards to substrate, and under normal fasting conditions, when the free fatty acids levels are high and glucose levels are low, the primary myocardial substrate is free fatty acid, whereas in postprandial conditions it shifts from free fatty acids to glucose, and hence FDG can be used for that. These are just examples about the normal variations in the heart. You can see that it can vary from almost no uptake to intense uptake, and these are FDG PET scans for oncology purposes. You can see that there's a wide variation with moderate or modest in between as well. And these are variations in the same patient over a period of time. Again, in the same patient, it can differ a lot. So the problem with these kinds of studies is the hormonal milieu under which we have to do these studies, and they are very complex to control and can cause problems and lead to a suboptimal study down the road because the uptake is very, very, very variable and dependent on a lot of factors, especially the patient dietary preparation affects the studies a lot. So basically, depending on the indication for the study, you might want to suppress the normal cardiac uptake of FDG, or you might want to encourage the normal cardiac uptake of FDG, depending on what you're looking at. You're looking at scar or viability, or looking at sarcoidosis. The intention is completely different. And so if you're looking at viability, it's say patients with chronic ischemic heart disease with dysfunctional myocardium, I think you had to talk about that. In those cases, or in conditions where you want to evaluate for a scar, say for persistent arrhythmia and you want to do an EP procedure for ablation, so you look for scar, versus infection and inflammation like cardiac sarcoidosis. So when you're looking for viability or scar, you actually want to encourage the normal FDG uptake in the heart. Whereas here, you want to suppress the normal FDG uptake in the heart. So the patient preparation is completely different. So there are various ways to encourage the normal myocardial FDG uptake. You could basically modify the patient's diet a day before the scan. You could try glucose loading, oral or intravenous. You could try the insulin euglycemic clamp method, which is very rigorous and not done on a routine clinical basis. Or you could use SAP-MOX, which is unfortunately not available in the US. It is available in the Europe though, so some people use it there. At our center, we use a high-carb, low-fat diet on the day prior to the scan, and then tell the patient to have breakfast with high carbohydrate content 1 hour prior to the scan. And if necessary, on top of that, we might give the patient oral glucose. Now, bear in mind, in patients with diabetes, this does create problems. So we check the blood glucose. If it's less than 110, we give oral glucose loading and then proceed with FDG. If it's more than 110, again, we give the insulin. We might give glucose loading with insulin and then do the study and then administer the FDG after that. We hardly do any intravenous glucose. We don't do the hyperinsulinic euglycemic clamp, and SAP-MOX is not available for us. To suppress the normal myocardial uptake, there are again multiple things that have been tried. Prolonged fasting, dietary modification, heparin has been tried as well, or a combination of the above maneuvers. At our center, we tell the patient to have a low-carb, high-fat diet and high-protein diet, followed by an extended fast of about 12 hours. And that seems to work for us relatively well. We actually have to tell the patients what they can eat and what not to eat, because lots of times it's not clear to them what is low-carb or high-carb. So these are just schematics about what happens with coronary artery disease in the chronic setting, and you can have an array of findings where the myocardium could either be necrosed and scar, which is non-viable, or stunned or hybernating and viable. And there are lots of studies where they've shown that patients do best with revascularization or surgery in spite of the advances in medical management. But surgery has its own peri-procedural morbidity and mortality, so you need to select patients that will benefit the most from these, and that's where the evaluation of these patients for myocardial viability comes in. Cardiac PET with myocardial perfusion Cardiac MR is coming up for that as well. In patients who have relatively normal flow or significantly reduced flow, it's not a big deal to differentiate between the two. It's the intermediate declines in the blood flow that need more assessment. And so you have to assess it in conjunction with resting blood flow with FDG metabolism flow. This is our protocol for that. And you get three possible patterns: normal blood flow, normal metabolism, that's normal; decreased blood flow, decreased metabolism, that's necrose or non-viable. It's the intermediate decreased blood flow but normal or increased metabolism, that's the flow metabolism mismatch, that's considered the hallmark for dysfunctional but viable myocardium. These are just some examples to show that there is a perfusion defect but preserved myocardial metabolism in that area. Perfusion metabolism mismatch, that shows viable myocardium. And you can again plot these. There are various ways to look at it. You can actually quantify, and here you can see that 79% of the defect is viable, which translates to about 11% of the total myocardium, or 21 grams. So there are ways to quantify this, and these quantifications help the surgeons a lot to determine how well a patient will do and how much symptomatic benefit is expected after a successful revascularization procedure based on these quantitative studies. Some more quantitative studies. In the sense of time, I was given only 10 minutes, so I'm going to cut short on that. And these studies have been validated. They show that they predict functional recovery, periprocedural risk and mortality, and those kinds of things. So identification of viable myocardium indicates actually a prompt need for revascularization. So if you find viable myocardium in a patient with chronic ischemic heart disease and dysfunctional myocardium, then you should promptly take the patient for revascularization. And if not, the patient may have a bad outcome. Some more patterns, some more examples. Moving on to scar imaging. We do this in patients who have recalcitrant arrhythmias of the ventricle and need ablation of their area. This is a patient who you can see that there's a big scar in the proximal basal and lateral posterolateral wall, and that's where when they do the EP, they have a good map of the electroanatomic bipolar voltage map of the ventricle, and it correlated pretty well. My EP guy person tells me that the scar imaging helps them a lot to decrease their procedure time, and they go right for the scar. They usually find a tract in that scar area, that's the culprit area, and that's the one that needs to be ablated. I've got several other examples, but I took them out because of a shortage of time. Moving on to cardiac sarcoidosis, this is where you actually want to suppress the normal myocardial uptake. So in patients who have extra cardiac biopsy-proven sarcoidosis and relevant signs and symptoms like abnormal EKG, any palpitations, arrhythmias, and something that evokes suspicion, these basically need to be evaluated for cardiac sarcoidosis, because if the cardiac involvement of sarcoidosis is found, then these patients have poorer prognosis. There are lots of consensus statements and even the Japanese health ministry guidelines that actually say that they need to evaluate for cardiac sarcoidosis. The two modalities that are recommended for that is MR and PET. Okay, yes, I'm going to. And so basically what you see is various patterns, and normally you shouldn't see any uptake. If you see increased uptake in a part of myocardium, that's bad. And then depending upon the perfusion abnormality, you can further grade the degree of sarcoidosis, and it actually reverts with time as well. And you can do a whole body scan to see extra cardiac involvement as well. So with that, I'll stop, and thank you for your time.
Any questions? Yes, please.
I've sometimes seen left atrial once in a sarcoidosis patient. Sometimes some oncology patients have them.
Without any uptake in the ventricle?
Is it just a hodgepodge of different things, or could there be any value in that?
So left atrial uptake without ventricular uptake, I would be very cautious to interpret that. We see a lot of left ventricular uptake, or even sometimes right atrial uptake in arrhythmias, and that would be the more common cause. If it's in the medial, usually it could be some misregistered intraatrial septal uptake that can be seen as an atypical brown fat activity as well. So I would be cautious to interpret that in the absence of uptake in the ventricle. Any other questions? Thank you.
That uptake, what do you call that?
In which situation? In normal normal oncology study or a specific cardiac study for arrhythmias? Atrial fibrillation flutter. The uptake is more because of hypermetabolism in those areas.
PPT, slides, PCSK9.
Thank you, Dr. Amol.